Hi, everybody, and welcome to the Broken Science Initiative Medical Society webinar, Push-Ups Before Push Time, Exercise and Pregnancy Demystified. This is by far my favorite title ever. We are so thrilled to have Dr. Christina Prevett with us.
So we are going to talk about exercise guidelines in pregnancy. So we're going to go very, very broad, talk about some of our general recommendations. And then I really want to systematically tackle some of these myths and misconceptions around movement and physical activity that are very prevalent in the exercise and pregnancy spaces. It's important for us, first of all, to recognize that just because you are pregnant, the demands around exercise or the need for exercise to promote health doesn't change. And I think there's this belief system that I pee on that stick, it is positive. All of a sudden, all of my exercises need to change. I need to be hyper aware of all of these things. And the answer is simply that that is not true. Where we are right now is that we have an overwhelming agreement in the obstetrical space, in the exercise space, that low to moderate intensity exercise is okay. Where I am coming out with my research is to allow individuals to push exercise as much as they want to push exercise based on their individual history and exercise, their goals in pregnancy, their goals postpartum, and how they are feeling within their body in each pregnancy, and including each subsequent pregnancy, because their goals in pregnancy 1 may not be the same as their goals in pregnancy 3. Up until recently, and I would say even up to the last 3 or 4 years, we just didn't have this accumulation of body of evidence that would allow us to feel good, from a liability perspective, even to be able to come alongside person 3. There is no such thing as a safe versus unsafe exercise in pregnancy, outside of anything that is going to cause a blunt force trauma to your abdomen. There is exercise that your body is ready for, and there is exercise that you are not. I have been running the last year and a half, and so I worked myself up to a half marathon. My body is ready for that volume. But I wouldn't take a person who has never exercised before and said, let's sign you up for a marathon on the weekend and see how you do. The first myth is that your exercise choices could cause miscarriage. There was a lot of belief that for individuals, particularly that were very working in very high intensities or vigorous intensity exercise, that they needed to bring down their intensity in the first trimester because of risk of miscarriage. Where we see some of this discussion happen is infertility, because there seems to be this U-shaped curve where individuals who are not exercising at all have lower rates of fertility. Those who are exercising at moderate intensity have higher rates of fertility, and then there's a little bit of a dip in the high to vigorous intensity. But again, even in those associations, there's a really big confounding variable around appropriate fueling, where our athletes who are exercising at really high intensity tend to underfuel. And when you are underfueling to not meet the demand of your exercise, there's a higher prevalence of anovulatory cycles. This is a big one, and I think this is probably the biggest one in the functional fitness space, is that if you see any coning while you are exercising, you need to stop immediately, because you're going to ruin your core wall. You're going to give yourself diastasis recti. And we really need to talk about this one, especially towards the end of pregnancy. Most people are not going to be able to avoid coning. They're not, because your rectus muscles are sitting too far away. And that's just because you're pregnant. And I don't want to avoid strengthening your core wall, because it's important for your core to be strong. So I think about coning more as a movement fault that I'm trying to minimize versus a thing to be avoided and feared. And that reframe is really powerful. I'm not saying that I'm going to ignore coning, but as I have more and more of these clinical stories, as I think more about what our research says and what it doesn't, I have moved away from a lot of my fear-focused messages around DRA. All right, this is my area of research. And the myth is don't lift more than 20 pounds. Now, I would say that the percentage of obstetrical providers now, at least around my area, that are kind of buoying or putting a max on the amount that individuals can lift is getting lower. But it is not zero. And some people will say 20. Now I've heard people boost from 20 to 50. And the question is, do we have a cap at all? The first thing that I think is really important is to understand where this came from. When we took a critical lens and looked at the dosage, we understood where this 20-pound cap came from. What my first introduction to my postdoc was doing was trying to get an idea of heavy lifting in pregnancy on postpartum health outcomes. And so we did a cross-sectional survey of almost 700 individuals who had lifted prior to and during their pregnancy. And we said, how did you modify? What did you do? What did you continue doing? When did you stop? And what did your delivery outcomes look like? And then we compared it to national averages. And so similar to what we see with resistance training in lower intensities, right? Those who lifted heavy, so at some point in their pregnancy, they lifted more than 80% of their 1 rep max. They had lower rates, again, of perinatal mood disorders, gestational hypertension, preeclampsia, and gestational diabetes, cesarean section compared to our general population statistics. And so, again, we need to kind of be thinking about how some people, it's not going to feel good for them to hold their breath during pregnancy. They're going to want to modify away. Others, they're not going to feel that way. And both are fine. Kind of going from resistance training to aerobic training, there is a lot of individuals who will explain or use a threshold of don't exceed X beats per minute. So some people say 150, some people say 140, etc. And where I think this came from, don't quote me, but this kind of makes sense to me, is that we feel very comfortable in the low to moderate intensity space, right? And so if we think about our very crude, not super accurate, but for the case of my argument, without going into some of the longer formulas for heart rate, if we take our crude estimate of 220 minus our age at first pregnancy right now in North America is 30. 220 minus 30, that's 190. And we take about 60 to 70% of that. We're kind of getting into the 130 to 150 space. And so if we cap at 150, then we can say we're pretty firmly in moderate intensity exercise if we cap it at 150. But what has happened is that we took this, instead of like a suggestion of being in moderate intensity, we kind of took this as an absolute, and then we kind of unraveled from there. Some individuals who say, like, I've been riding this horse for over 10 years and I feel more comfortable on this horse than in a car. And so then it begs the question of, like, if you have that trust in the horse, does that change the risk profile? This is starting to become a very interesting area of practice. Now, are we at a point where I can say confidently, like, you can play soccer right up until delivery? No. But it is starting to ask the question of, is this a blanket question, a blanket statement kind of thing, or is there a little bit of wiggle room? And I think what we're going to see is that there's a bit of wiggle room. This is all great when individuals are used to exercising or they're exercising in uncomplicated pregnancies. Where an additional layer of concern comes in is when complications come up. I don't want to misspeak, but this is not the case in all areas. But many of our restrictions on exercise in the presence of complications is not that we have evidence that exercise exacerbates difficult outcomes or adverse outcomes. So it's not that we have evidence that if you have preeclampsia, for example, that exercising with preeclampsia is going to make fetal outcomes worse. What we know is that our baseline risk is higher, and so you're kind of locked down from that perspective. This is not true in every complication, but in many, we actually have no evidence on the role of exercise and how it manages risk of adverse events in the presence of complications. And that is starting to change, which is really exciting to see that we're having some of this data. And the second area where I kind of challenge is that the idea is that these pelvic rest recommendations are meant to reduce strain on the cervix, on the pelvis. Are we being net helpful or net harmful? And I think that's where our research really needs to come in and give us some firm conclusions here. My job or my goal with my research and my team's research is that I don't want to bubble wrap you. I want to bulletproof you, right? Because being pregnant is hard. Being pregnant deconditioned is harder, right? When you're being postpartum, it's hard. Being postpartum deconditioned, it's harder. And so we want to reframe this around, can we think about, is it harmful to restrict exercise, especially when we don't have any evidence to back us up? And now I'm not saying that we're going to reduce all of our restrictions and get rid of any of our complications. I'm not saying that. But what I am saying is that the risk of deconditioning has to be a part of the conversation when we are giving these recommendations.